Good afternoon, everyone. Thank you for joining our session today, and for those that came yesterday to our panel for the announcement of our Kraft Prize for Excellence in Innovation in Community Health. You'll see this as a really terrific part two. We have several people here who are going to talk about the part two of our conversation yesterday, right? There's a significant need for innovations and technologies to fill the gaps that we currently see in improving community health outcomes. And some of those technologies and innovations can take many different forms. Today, we're privileged to have 4 distinguished panelists who are doing just that. The panelists today have leveraged technology and outside-the-box thinking to improve outcomes in lung cancer, addiction, maternal health, cardiometabolic disease, and developing supports for social determinants of health. With us today is Chris Thompson, CEO of Sober Sidekick, Alicia Lalani, Chief Growth Officer at May, Kwame Liddell, founder and CEO of ThriveLink, and Dr. Jeff Yang, a thoracic surgeon at MGB, founding director of the Center for Artificial Intelligence and Innovation Research, who started the American Lung Cancer Screening Initiative to highlight the importance of lung cancer and screening. So we're going to dive right in with the question first for Kwame. As the winner of the inaugural Kraft Prize for Excellence in Innovation in Community Health, I'd love, Kwame, for you to share a little bit more about the work that ThriveLink does, how AI has helped to fill the gaps and reduce the barriers that otherwise may have seemed insurmountable.
Yeah, it all starts really just like grounding, thinking about where we started. I'm an emergency department nurse, and I jokingly tell people I was a travel nurse before it became cool, and I cared for people all over the country, in rural areas, and I grew up in Chicago, where I cared for so many patients that didn't need more health care. They needed food, housing, transportation. They already had medications prescribed to them, but they were having a stroke because they couldn't afford them. And as a bedside nurse, there was no way for me to easily get them into this program that I know exists and I know it's available to them. And it really struck me, and really when someone asked me this question earlier, we all see, especially in healthcare, we see so many problems. Why did you step out and go try to solve this one? And it was really personal to me because my uncle had a massive stroke when he was about my age. And he otherwise looked like a fit person. He rode motorcycles and all those things, but he couldn't, but we lived in a massive food desert, and our grocery store was really like a meat market, honestly. And really stemming from those lived experiences, it made it easier for us to stay centered around designing with the health systems that we serve and the patients that we serve. So what ThriveLink does is it's an AI agent that you can speak to over the phone, and you vocalize your answers to whatever program you want: Medicaid, food stamps, utility, medication discounts programs, care management, etc. And you don't need a smartphone or the internet, so they're able to talk. And thinking about some of the barriers to getting that, people think it's the technology, but it was really more making sure that what we created fit within the workflows of the providers that would use it. If you create something that adds 12 more clicks for nurses, it's not a good product. It's not going to fit the system. It's not something they can do consistently. So that was the first thing, really making something that is 1 to 0 clicks, and that's for all of our partners. In 1 to 0 clicks, they're able to see, hey, this person needs to go to care management. Now ThriveLink will take the rest of the work. The second thing was cost. So a really important thing for us is, in our mission, we had to build something that community clinics, FQACs, Medicaid plans could afford. Had to be something they could afford. Because if we built this incredible technology, but it doesn't reach the population we aim to serve, then we didn't reach our mission. So really, we worked in building a platform that's cheap enough for a health system and clinics to be able to implement, but also something that is billable for health plans. So both the patient, the health system, and the health plan all benefit, and it's really an ecosystem effect financially and from a positive ROI.
And we'll come back and talk a little bit more about design and reach, because there's so many of the principles of how you built and designed ThriveLink that applies to the work of all of our panelists today. And you'll see a theme emerge of some of these guiding principles for scaling innovations. Dr. Yang, I'd like to go to you next. And you have a very interesting perspective because you're a surgeon, you are the founder of the Center for AI and Innovation Research, but then you also created this amazing initiative out in the community across 50 states to try to raise awareness around lung cancer screening. And I'd love for you to talk about how you, right, like how those all came together to create, you know, and to kind of catalyze the work that you do.
Thank you. So for me, lung cancer is personal. My cousin passed away from lung cancer when she was 41, and she was a mother of 2. And my grandfather also died of lung cancer. And what I learned over the years is that most people don't know the importance of finding lung cancer early. So lung cancer screening, if you find lung cancer early, then it's very treatable, it's very curable, and patients do really well. And right now, there's a lung cancer screening exam. It's very simple. It's called a low-dose CT, and it's just 90 seconds. So it's less than 2 minutes. You just get on the scanner. You don't even have to take your shoes off, and it's painless. It's free. It's covered by all Medicare, private insurance companies, and here in Massachusetts, Mass Health covers it. It's recommended by all major medical associations, but only 20% of people who need to get screened are actually getting screened. So in other words, most people are not getting screened. And you want to contrast that with breast cancer and colon cancer screening, where most people who need a mammogram or need a colonoscopy are actually getting screened. And the other thing a lot of people, I don't think, realize is the scale of the problem. So lung cancer is the #1 cancer killer in the world, in the US and in Massachusetts, and it's the #1 cancer killer for women as well. I think most people, as I was walking to the registration today, somebody guided me, and I just was curious if it was still true for today. But I asked the gentleman, what do you think is the #1 cancer killer of women? And he guessed breast cancer, and that's what most people still think. They think breast cancer is the #1 cancer killer. But if you add up breast cancer, cervical cancer, and ovarian cancer deaths, these are all the top cancers affecting women, there's still more people dying of lung cancer. And so for me, I felt it was really important to get the message out, to try to raise awareness. And so that's why I started this nonprofit where we have leaders like Jacob Baird and Alex Drew and Brian Redner helping me teach people about lung cancer screening in the communities. And so far, we have really tried to engage the student community, both initially college students, but now high school students as well. And so we have over 1,000 students working across the country teaching community members about lung cancer screening.
So they're literally your agents of change and boots on the ground. And we'll come back, because I do want to ask a little bit about kind of the translational side of the research, but I think, you know, that sense of arming a small or a large workforce out in the community delivering the messaging around lung cancer screening and awareness has been just terrific. Chris, I'd like to go next to you. You designed Sober Sidekick with patients and communities at the center, but also with empathy in mind. And I would love for you to talk about how Sober Sidekick has leveraged that sense of kind of community, patient-centered design, how you leverage connectivity. How did you initially land on this idea and the design?
Yeah, not on purpose. I'm someone who, for years of my life, you know, I was a raging alcoholic. I did not expect to live much longer. I've been in the emergency room multiple times due to my addiction. I know what it's like to be in the psych ward on the 5150 hold. And I know what it's like to be homeless as a result of my addiction. And I didn't see it happening to me. I was a college athlete, you know, I was an honor student, and then 3 years later I find myself waking up on Thanksgiving Day 2018, and I'm alone, I'm in LA, I don't know LA, I've been walking around for a week straight, and the right people showed up for me at the right time that day, and they weren't mental health professionals. They were just people who were a little bit further along on their own recovery than myself. But they helped me see, they helped me feel seen in a way that I hadn't felt seen in years. And that day became day one of my comeback story. And about 30 days later, I asked myself, could I build an app that harnesses empathy, peer support, and community in the same way those people showed up for me? It turned into something I never expected. You know, I was living in a halfway house the first year and a half. During that time, I found one of my roommates dead, blue in the face. And, you know, what I learned from that experience is that, you know, the problem is not getting more people into rehabs, because relapses, suicides, overdoses are things that don't happen in clinics or therapy sessions. They happen when people are alone. So designing a platform to meet that need, to be there in the most critical moments, you know, knowing what problem we're solving made the biggest difference in solving a problem that the rest of healthcare is not equipped or focused on, made all the difference. So back to you.
So you can probably pick up on the theme again, right, of community patient-centered lived experiences that have guided the work that all of our panelists will be describing today. I want to have the first round of questions and describing their organization go to Alicia from May. Alicia, I would love for you to describe the work that May is doing nationally to improve maternal health, how you combined evidence-based practice, in this instance, matching pregnant individuals with doulas, while also building a digital platform to expand access. Tell us a little bit more, again, about the design, what were some of the principles, and tell us a bit about what May does nationally.
Absolutely. Thank you so much, Elsie. Hi, everyone. Nice to be here. So May is a maternal health care solution really built to address the specific clinical, social, structural, behavioral, mental health issues related to pregnancy and those that are birthing peoples, and particularly those birthing people with the most striking disparities in health outcomes. And so we really built May with Medicaid in mind, right? When we think about moving the needle on maternal health outcomes, we knew we needed to focus on the hard place. Everyone knows here Medicaid covers about 40% of births across the US, upwards of 50 to 60% of Black births in the US. And so if we needed to think about where those biggest disparities in maternal health outcomes lie, it was there. And so what we've done is created a space where complete digital care meets on the ground culturally aligned supports preliminarily in the space of community-based doulas. And so we're really focused on building a doula-led model of care for a couple of reasons, right? One, as Elsie said, is the evidence base, right? There's just such outsized impact that this provider type, that this community health worker in the form of doula can provide to these mothers, and we see it across the board. We've heard the stats, right? Doula-assisted mothers are 4 times less likely to have a low birth weight baby, 2 times less likely to have a maternal health complication. Even in our population across the 10 states that we work in, we're seeing a nearly 30% reduction in C-section rates. We're seeing a nearly 40% reduction in preterm birth rates for those doula-assisted mothers and beyond, right, with our digital health platform. And so that was really particularly important to us on that level. And that's just the clinical outcomes, right? If we think about the mental support, the emotional support that doulas bring, it was just really paramount for us to put them at the center of our model of care. And the second component of why we did that doula-led model of care was it was just really impeccable timing, right? Right place, right time. When we launched May, there was 4 states that were covering doulas as a covered benefit for Medicaid beneficiaries. As we sit here today, it's 25 to 26 states. 7 are in the process of implementing a doula benefit now. I think a dozen more have introduced some sort of legislation, right? So we were riding that wave, and it made all the sense in the world. And so for us, what that meant was we were coming in at the ground level at a number of these states and really building that network from zero, right? Being the first to operationalize this new cadre of providers and figuring out how it works in in the most regulated of regulated spaces, right? Figuring out how we get these doulas NPIs, how do we get them credentialed with the plan, then how do we actually get to utilization and actually get paid out for these very newly minted CPT codes. And so that was something that we have focused on a lot, and we have built a fully back-end administrative support for these previously community health workers, these members, or these doulas who are in private pay only or in community, how to bring them and bring them to a space where they could scale and grow more with more members that were previously barred from engaging in doula care. Cost prohibitive otherwise. Yeah.
So I want to pick up and maybe a follow-up question for you, Alicia, about that, because what May has done is operationalizing an evidence-based practice, right? You just told us doulas work for NTSB C-sections, for maternal health outcomes, even some evidence about outcomes in that first postpartum year. But there are also, what you've had to do is operationalize policy and legislation, and that comes with its own set of challenges. So can you talk a little bit about, right, like now that you've operationalized an evidence-based practice and research, how do you then operationalize something where there's changing policy, legislation that's making reimbursement easier? That must come with some challenges in kind of scaling across the country.
So much. No, there's so many. I think there's two moments in my life when I'm like, oh, this policy is going to change everything. One was when the ACA was passed, and then when doula legislation started coming and was being passed at the state level, and everyone was cheering. Everyone was so excited. This is going to revolutionize maternity care for the population that needs it the most. But the Everest that it was to get to operationalizing it and actually getting utilization and access for it was just a whole different level, right? We have these doulas who are making $3,000, $4,000, $5,000 with their private pay clients, and then we're saying, hey, we're opening up Medicaid for you. Come, there's a whole new set of members that are going to want to use you, but you're going to get paid like $1,500 for it. And also, hey, members, you've never been able to access these doulas. They cost $5,000, but you can get it for free. And they're like, what's a doula? Right? And so for us to be able to take both sides and say, how do we provide that education to these members to say, here's what a doula can provide for you. It's emotional support. It's continuity of care throughout your perinatal journey. They live in your community. They know what you're going through. They go to the same grocery store you do. They might go to the same church. They're going to call soda pop the way you do, right? Just examples of that, and they're going to get where you're coming from. And then for the doulas to say, hey, we're going to help you through the process, right? All of this is really confusing. Getting an NPI, they're like, what's an NPI? Getting through the state registration process, getting credentialed with the plan, submitting a fee-for-service claim. There's a bunch of providers. Who's ever submitted a fee-for-service claim? Raise your hand. It's hard. It's really hard. And there's a reason that not a lot of people do it. And so for us to say, hey, somebody who's never worked in a reimbursement space, here's how you submit a fee-for-service claim and a clean claim, and then get your payment for it, right? All of that just took a ton of workflows and operations that didn't exist. We had to work with the plans hand in hand, right, to say, hey, this is a provider agreement. There's not continuing medical education requirements for this type of provider. They don't work in a facility. They work in community, right? So there's just these nuances that we needed to figure out and that we continue need to figure out, right? As we're getting on the ground, working with the states, working with the plans, and designing a space where, hey, this will work and there's going to actually be utilization, right? It's not just a policy for policy's sake to say, hey, we've checked the box, we're doing this for our most vulnerable populations, but actually getting utility from it and then seeing the outcomes from it. And I think for us, that's been so paramount. And where we are now is that our population has they use their doula at an 11 times greater rate than the national population does. So we have a 70+% engagement with their doula, and we're seeing the outcomes as a result. But that just took so much more legwork and operations than we even imagined, than just speaking the same language across the different players that policy impacted.
So you've had to operationalize policy and legislation. And Jeff, I'd like to go to you because in some ways you've had to translate and operationalize research that you're getting from large data sets and kind of use that to allow you to be even more precise with how you tackle, right, your work in lung cancer.
Mm-hmm.
So tell us a little bit about that different side of translation, right? It's like translating evidence to improve the work of that you do around lung cancer screening.
That's a great question. So when we're out there in the community, we teach people about lung cancer screening, but in order for people to qualify for lung cancer screening, you have to first be eligible. And there are these guidelines on who actually can get lung cancer screening. And right now, the body that provides the recommendations, they're called the USPSTF, and you may have heard of that. And the criteria that they set for lung cancer screening is quite complicated. You have to be between 50 and 80, you have to have smoked greater than 20 pack years, which means that it's a combination of how many cigarettes you've smoked a day and how long you've smoked, and then you have to be currently smoking or have stopped smoking within the past 15 years. So it's a mouthful. And as we went out there in the community, we started realizing a lot of people aren't even eligible to get screened. And then when you look more broadly, every year 130,000 Americans who are at risk of being diagnosed with lung cancer. So in other words, they are going to get lung cancer this year. They wouldn't have even qualified for lung cancer screening. And so it's one of those situations where the community outreach actually informed the research. And what we've been trying to do is look at large-scale epidemiological cohorts and use the analysis of that to realize that, for example, one simple change, instead of asking people how many cigarettes do you smoke a day and how long you've smoked, you just have to ask people how many years have you smoked. And instantly, if you use that as your criteria, many more people would be eligible to get screened. And so we're hoping through those types of studies, and right now we're working on a prospective study screening Black women and men who are eligible to get screened, who are at risk of developing lung cancer. And we're hoping that study, combined with the other studies that we've done, will actually be able to change the USPSTF criteria in the future.
So I love that example, because that example is actually starting with the community outreach, informing how you shift the questions that you're asking of a large data set, which is, right, that cycle is what we always love to see, is that it helps with iterating on kind of a solution. And I love that idea of, right, the voices of the community that you're seeing and hearing about out in the community is guiding even some of the research that then will make an even more precise solution come out of it. Chris, I want to go back to you and ask you a question about the work that your coaches do, that the folks that you connect people to through Sober Sidekick are able to do. You know, we hear so much about the biggest challenges in treating addiction is fighting that stigma and that surrounds people in recovery. And I know that you shared a bit kind of the myths and misconceptions, and I'd love for you to talk a little bit about what does a typical interaction look like with Sober Sidekick? As you were designing and as you've been implementing, what are some of the myths and misconceptions that you've had as you've been scaling the initiative and the program across the country?
Yeah, well, from a healthcare perspective, I think it's really easy to conveniently ignore how fucked up our system is around addiction. You know, I met many people while in rehab saying, I'm being paid to be here. The sober living I lived in for a few years, the majority of their revenue came from a kickback every time someone relapses, and I send them over to my friend's facility over here. And, you know, for us, it's about keeping the main thing, which is prevention. And there's a Harvard case study about our decision. Once we realized there wasn't a way to have rehabs as customers, we shut down our only revenue stream while having a VC telling us they'd be willing to lead our round if we were willing to scale it. And, you know, it's trust at the foundational point with our members. And it's the main thing is prevention. And in so many areas of healthcare, with addiction being one of the worst, there's actually human trafficking laws written to try to prevent all the kickback and referral systems going around. So for us, the way we monetize the platform is by reduced readmission rates, reduced relapse rates. The average person who goes to rehab once goes 7 times. 95% of those who complete a stay in treatment have relapsed within a year. And from a member experience perspective, it's all about what can we do to keep you on track. One of the things I say is if you optimize for what's billable in healthcare today, especially with addiction, you are not optimizing to prevent funerals. And if you optimize to prevent funerals, you are not optimizing for what's billable in healthcare today. And the amazing thing, from the roots in the beginning, when we only had 100 members year one, it's those 100 members stayed with us, engaged, and now they're the ones giving support over 1,000 times in the platform to the newcomer. We've harnessed karma and empathy in a way where our year one retention is off the charts. One of the biggest stats we've seen is if we can get someone to engage with a peer once on a monthly basis, which costs our healthcare systems nothing, their chances of relapse go down 51%. And this is on a sample size of hundreds of thousands of people. As a result of having over 1 million users, we're the largest data set on sobriety in the world. We're the first to know when someone falls off track, and we can predict with 96% accuracy the likelihood of anyone on our member to relapse in the next few weeks. So trust really was the foundational ground that we built this platform on. And then everything else, it just came down to data, A and B testing, and measuring everything we do to the outcome of does this reduce relapse rates or does it not? I'll kick it back to you.
It's really interesting though, Chris, because you had to make a really difficult decision to walk away from funding because the outcome wasn't what you, right? Like to prevent that kickback, but also really understanding what's the important outcome.
Yeah.
And the important outcome isn't like a handoff to recovery. It's actual prevention of a relapse.
Yeah.
And it sounds like that allowed you to make that decision with some confidence that you were headed in the right direction. But I can imagine that was a pretty challenging decision to make at the moment.
Well, for me, I'm trying to stay alive, and this is part of my recovery. And, I know that, every decision when it comes to our platform, if we don't keep the members first, then I'm going against the values of the people who saved my life. And, so for me, it's just trying to stay true to the principles that keep me alive in my own recovery.
Yeah. Well, I'm glad you did, because I think it gets to what works and for who and how and what are some of the tough decisions sometimes that we need to make to keep these innovations and programs to do what we hope they will do, which is improving outcomes. Kwame, I'd love to go to you next to talk a little bit about, in this kind of conversation about challenges and wins. One of the challenges that you talked about yesterday is integration with health systems. It's having to really bring in the voice in your case, not just of patients and communities, but clinicians and systems, and what are the outcomes that the system is trying to achieve, while you're also thinking of kind of the patient and the community member at the center. And I wonder if you could talk a little bit about those challenges and wins and how you've kind of overcome them as you've implemented ThriveLink.
Yeah, in that realm, it's really important to be multilingual and be able to have those conversations appropriately with providers, patients, and payers. Really create that ecosystem effect. And something that was important was, and something that people are surprised about, is that the priorities for the frontline staff who are using the product and communicating with patients is not always the same as the leaders who actually pay for the thing. So it was important for us to be able to speak multiple languages. It's easier for me to share that telling stories. So we work with a health system, actually tell of 2 different health systems with really great outcomes in both. One where readmissions was a real issue for them, especially among older adults. They knew that, and there's so much research that shows if you give people healthy food who have uncontrolled diabetes, who are admitted for uncontrolled diabetes and congestive heart failure, it reduces readmissions by 25%. It happens every time. But how do you operationalize that as a health system? How do you actually, in all this world of things that they had to do, how do they operationalize that? So they created a system where every patient who gets discharged with those 2 diagnoses, they get ThriveLink. They talk to AI, it delivers food to their homes and signs them up for SNAP and signs them up for medically tailored meals that's covered by their health plan. So it costs the health system maybe $5 to prevent a readmission per patient. So we're able to do that, and not only are we seeing so many patients happier about their visits, they're getting healthier food and getting to these programs that they frankly should have already been in. And we saw a story where there was a gentleman who was homeless. He didn't scream that he was housing insecure while he was in the hospital, because when they asked, do you have a place to stay? He said, yeah. But for him, it was the car wash, in the local car wash in the area. But it was the first time that there was something that he could navigate himself through the system. Because with ThriveLink, you just talk over the phone. He may have used the payphone. He got his medically tailored meals delivered to the car wash. He got his insulin delivered to the car wash. And he showed up at a primary care visit. He did his annual wellness visit. Now, when I say that in an ecosystem perspective, the hospital prevented a readmission. And we found for that specific patient, unnecessary emergency department visits. So, because he didn't have insulin, so when he felt like his glucose was out of control, he would go to the ED, get insulin, and go back out into the community. So you saw the hospital right away, really clear benefits. Then the health plan, he was a member. He was a part of a value-based care system. So he had an annual wellness visit, and now he even has the opportunity to achieve his controllable A1C quality measure. And when you really think about how to make an ecosystem when you really think about how healthcare should be, that's how it should work. When you go into a hospital or a doctor's office, I should be able to access all these programs at once. That is not what happens in the United States healthcare system. But we created something where it fits into the provider's workflow. It benefits the health plan. They're touching patients that they couldn't touch otherwise. They already tried to call him. He has a different number in all these different ways. And now we learned about it from the primary care perspective once he began to participate and actually go into his annual wellness visits. There are so many stories. Even another patient in Boston won the Boston Housing Lottery. At 70 years old, it was her first time ever having her own home. It is not because she didn't qualify, it's because she just needed something to help her do the paperwork. So really, the barriers in that, there are so many things, the payer system, the workflow, and all those things that we really had to overcome and understand so that health systems can achieve their goals and be able to do it in a way that's efficient. And patients are actually having these really incredible experiences every day that we're really, really proud of.
Well, I think you all have given us such really terrific perspectives of what it really takes to do the work that each of you do to improve community health outcomes. And you're in a room full of people who are looking to do the same. And I'd love to do a round, in this case, a question for each of you to address, which is, in a room full of people who are thinking about innovation and bringing innovation or bringing programs into the community, doing in that phase of kind of translating from evidence or policy into practice, what are some of the, what are one or two lessons and kind of concluding ideas that you would leave this room of, right? How to approach that translational side of innovation to improving community health outcomes. And Kwame, maybe I'll start with you.
You know, I had a different answer until I heard Alicia talk a few minutes ago, thinking about doulas and using that as a real world example of why health systems and health plans should partner with the innovation community. And something we do at ThriveLink is we call it land and expand. So if you have this big problem, start in literally one clinic. Where's the problem most, where do you see it most within this large system? Let's start at this one place and be a partner to build things together. And a real world example, I share how we built the module. They needed to do work around readmissions. They found the things that would make the biggest impact, and we operationalized it for them. Now, something that we're thinking about is maternal health. And we're working with partners, and even through the Kraft prize, we're already learning what are the things that moms need when they find out that they're pregnant, when they have a new child. What do new parents need? Who knew how complicated putting together a car seat is? But one of the things that we're thinking about is, and I don't mean to put Alicia on the spot, I asked her yesterday, what states are you in? We're thinking about maternal health. How can we get doulas as a part of our system so when someone engages with ThriveLink, they can access all of these things in one place? So with the health system as a centerpiece, helping us understand the problem, understand the workflow, work with us as we work together to build out something through partnership so that they get the best experience, whether it be food, housing, healthcare, and beyond.
That's excellent. Jeff, next to you.
So I think my answer is more low tech, which is what we've learned is the importance of engaging the youth in our student community, both in the college student community and in the high school student community. What we found is, so when I was in medical school, a lot of, I learned that there's a lot of distrust of potentially healthcare providers in underserved communities. And when we first went out there in the community to teach people about lung cancer screening, I wasn't quite sure how people would welcome us. And what we found was that the communities we reached out to really embraced us. And part of me thinks it's because they saw the passion and the kindness and generosity of the students. It's, you know, we're all volunteer and we're all caring about people's health. And so I would encourage you, you know, everybody here to potentially mentor some students and help them get excited about what you're interested in. And in turn, the community benefits, but also the students really will learn a lot from you all.
That is excellent. Chris.
Yeah, I think it's really easy to look at our populations as victims. I was once in a meeting with a Medicaid MCO, and they described our population as sick people incapable of helping themselves, which is very, very different from my lived experience. And there's this egotistical idea that we're going to be the ones who fix these sick people. And what I've learned through this experience is the member outcome is the product. And for us, the member outcome is an epic, real-life comeback story. And for us, someone asked me how we got to over 1 million users. It was focusing on how can we turn the 100 people who are on our platform now into epic, real-life comeback stories. And then they brought in the next 1,000, who brought in the next 10,000, so that every time someone joins our platform, they're receiving support in minutes, if not seconds, while on their day one. And they do all the work. And some of our members have provided support over 10,000 times. And it's just our job to reward our members and show them their impact. One of our features in the platform, members can see their butterfly effect. You gave support 10 times, which resulted in a reduced relapse rate of X. And those people then went out and supported 100 more people. So we got to look at our populations as untapped resources where, you know, if we can show them their power, we can change the world. But we simply put, we don't have enough mental health professionals to solve these problems. The problems won't get fixed in these rooms. We've got to empower the people. We've got to meet them where they're at. No more trickle-down healthcare. Let's invest in comeback stories.
Let's go.
And harness superpowers, it sounds like. Alicia.
Yeah, You know, it's been so interesting just even listening to this panel and being part of the conference the last 2 days. I think there's this balance as entrepreneurs and folks starting to think about innovation is how do we leverage the technology for scale and efficiency, but maintaining human touch and human connection? And how do we keep that paramount to what we're doing, right? Even Chris saying the trust piece, right? How do we build that into what we're doing, but still use the technology and the incredible advances to help on the business side, right? Just as an example, for us, we have care coordinators that are talking to our mothers throughout their perinatal journey. They're doing a lot of this benefits coordination. They don't have to do that by hand. Let's go to ThriveLink. Let's use ThriveLink, let them do that. Then they have more time to just talk to mama, see how they're doing, what do they need emotionally, mentally, and the like. And you know, there's so many health plans that come to us and say, hey, here's our roster of members. Good luck, you're gonna reach 2 to 5%. We consistently reach 60 to 70%. We have a 95% engagement rate across our 10 state, 17 health plans. And there's no secret sauce, right? It's because the doulas are there. The doulas are talking to them. The care coordinators are talking to them. And then there's a digital platform that's supporting them and giving that insight. But you can't do it without that touch and that support and that trust. And I think it's finding the balance of how do you leverage technology to get that efficiency for a member, but also give them that support and that human connection that I think we're all craving.
Well, with that, we are at the end of our time, and I just want to say you all are champions of the work that to improve community health outcomes. We are so proud to be partnering with all of you through the Kraft Center and to really raise the voice of all of the work that you all are doing. And so with that, thank you all. And please join me in congratulating the panelists and the important work that they are doing. Thank you.
Thank you.